Good morning, everyone. I'm John from HTN, and welcome to this webinar today, where we're set to go in depth into electronic patient records. And we have a fantastic panel joining us to share their EPR journey and their learnings. And we have an overarching aim to share best practices and approaches and to go into what's worked well and perhaps what hasn't. But as well, I'm keen to hear from you in the audience. So feel free to tell us about your EPR journey, what's worked well and what hasn't as well. To do so, type into the chat. Really keen to hear from you. And as well, if you've got any questions that you would like to ask, do so in the chat and we'll look at those as we go. Final thing, as part of housekeeping, is that this session will be recorded and there will be a write-up done by the HTN team so you can read or watch it back at a later date. Okay, so let's first start with some wider introductions. So if I could ask the panel to do a brief introduction and to give us a quick overview of your EPR journey or progress to date. So Kira, welcome to the webinar. Could I start with you, please?
Hi, thank you very much for inviting me to this event. My name is Kira Moore. I am the EPR Operations Director for Bath, Salisbury and Great Western, and we're implementing a Oracle Health deployment next year.
Fantastic, thank you, Kira. And Kelsey, welcome to the webinar.
Morning, my name is Kelty Jameson. I'm the Chief Information Officer for Bermuda Hospitals Board. We implemented Oracle Health 3.5 years ago, and continuing on from there.
Fantastic, thank you, Kelsey. And Ian, could I come to you next, please?
Yes, good morning, everyone. I'm looking at somewhere that's hopefully as sunny as Bermuda. It's a beautiful day in Guildford, which is great. Makes a change, doesn't it? So anyway, my name is Ian McKenzie. I'm the interim CIO at Surrey and Borders Partnership NHS Trust. I started for 6 months nearly 2 years ago, so therein lies a tale. I've been involved with 2 EPR suppliers, really. Cerner for about 15 years on and off in 4 different sites, and most recently for the last couple of years with System 1.
Fantastic, thank you, Ian. And Mike, could I come to you finally, please?
Hi, thank you. Yeah, I'm Mike Hardman, a practice lead for software development at AirLogic and also EPR technology lead. I get involved at all stages of EPR deployment and diagnosis. Predominantly these days, I get dragged in to handle distressed systems that are struggling and help diagnose what is going on and keep a trust operating.
Excellent, thank you for that. Right, the first part of the webinar, it'd be good to hear about your journey in a bit more detail in terms of, did you have any challenges along your EPR journey? What might they have been? Were there any unexpected challenges too? And how did you approach those? How did you tackle those? What worked well, perhaps what didn't? So challenges is the first area of focus, I think. So Kelsey, could I start with you? So you're 3 years in, and you joined 2 months before the initial go live. So what were some of the challenges that you've seen?
So I would say my EPR journey started 15 years ago. I'm from Canada, and I've been implementing EPRs across Canada for over 15 years. And I would say the challenges have not changed a ton. So in those 15 years, they're more similar than they are different. Coming to Bermuda, we are the only hospital in the country, so not a lot of people to lean on for advice and experience. And I would say our biggest challenge was not knowing what they didn't know in implementation. So I believe that the most important part of implementation is actually starting before the vendor starts. In getting your standards and documentation standards together. And that was something that I think we didn't do necessarily here. By the time your vendor comes, you're hitting the ground running. You're on a jet plane firing over the Atlantic, for lack of a better term. And it's very hard to sort of get those standards together. And I always ask people, do you know how you want to take care of patients? And if you can tell me that, as an informaticist, I can build you a great system. But if you don't know that, it's very difficult to do you often take everything out of the box, and I'm not sure that's actually the best way to deliver a system that works for anyone.
Fantastic. Thank you, Kelsey. And Ian, could I come to you next, please? Same
Yeah.
question on the challenges.
Yeah, thanks, John. So, I mean, a lot of what Kelsey just said, I would completely agree with. Just a little bit of my backstory. I'm so old that I was actually involved in implementing a PAS system in 1986, patient administration system. So, and since then, I've been involved in 5 different EPRs. And broadly and fundamentally, I would say the challenges have been the same across all of it, really. Although they've probably got more complex as the sort of request from the system has changed and increased. But I was thinking about where I am now. So when I started a couple of years ago, so I'm in a mental health trust and we have System 1 EPR. So we'd implemented it in 2015, but long story very short, hopefully, we'd implemented it in a way that wasn't best for the trust. That's me being diplomatic. And there had been a program underway already for a couple of years to fix that. But when I started, I think it's fair to say there wasn't a complete understanding of what we were doing and why, and also how to do it. Yeah. So perhaps later in the conversation, we'll talk about what we did to fix it. But the challenge was, and I think it's common, is exec ownership and understanding of exactly what you've got, why you're doing it. And I would completely echo Kelsey's point about patients. It's all about patient care. If you cannot work out how your EPR is not aligned, that's the right negative way around, to patient care, you've got a problem to start with. So that's got to be your sort of fundamental golden thread through it all. It's not about saving money. It's not about admin processes. It's fundamentally got to enhance patient care. So that's a very brief summary.
Great points. Thank you, Ian. And Mike, I'm keen to hear your perspective from AirLogic and perhaps the customers that OHS providers that you work with.
Yes, so generally I would prefer not to be getting involved if at all possible, because I tend to arrive when things are I'd probably going a little wrong, and invariably they're not technological problems. They're usually like sociological or staff readiness problems that are really the root cause of what's actually happening. Generally, the failures that I tend to run into are probably because things like cutover planning wasn't done properly. So people, there was an assumption that training is complete, therefore we're ready to go live, rather than actually understanding true operational readiness. There wasn't a lot of, full dress rehearsals run. There wasn't properly named decision makers for each of the stages, and the go-no-go criteria wasn't explicit enough. There wasn't anybody ready to say, we need to stop this at this point. It's almost like the organizational pressure was, we're going to hit this delivery date, whether it matters or not, rather than is this actually going to be a good thing for us to do at this point in time. So it's usually organizational and sociological problems that really cause these sort of systems to appear to not work. Like, the systems are going to work, right? The technology is sound underneath all of these things, but the issue is getting them and getting the organization ready for that kind of a change and doing it in a way that builds confidence rather than undermines it. That's my sort of little spiel about that, really. I think it's not a technological problem really ever, and if it is, those fixes are usually quite easy to diagnose and fix, whereas the organizational ones are usually a bit stickier to navigate, usually political.
Thanks, Mike. Ian, would you like to come in?
Yeah, I just wanted to echo some of what Michael said and just add another thing, which I think is that happens as part of that process that Michael was describing as building up to going live. Right at the start, there was this sort of, ideally, some sort of vision about what was going to be done, and they were going to do 100% of something. There's like 100% implementation. And over time, for various reasons, financial, time, risk management, whatever, that gets watered down and watered down. So when you actually go live, you've gone live, and I'm making up the numbers, you go live with 50%. Yeah. And so the promise at the start has been watered down, partly through that process that Michael was describing, is when you are managing risks, and sometimes people aren't managing risks enough, they're compromising in order to get it over the line. So that date that was sacrosanct to somebody, partly, let's say, because another system's got to be replaced, ends up being a compromise in every regard.
Great point. Thank you, Ian. And Kira, keen to hear your perspectives on challenges and how to sort of overcome those.
So I'll speak from some of the experiences and lessons learned. So my first EPR was EPIC in Cambridge in 2014, and I think the world watched in all the news headlines around not being able to pull our data and reporting. So we were absolutely ready for the go live. Everyone was engaged. We're all behind it. But I don't think we realized the vast amount of work and optimization that would have to happen post go live, and how to keep that momentum going. And fast forward now, I think they have it now 12 years. You can see the great things that have been coming out of Addenbrooke's with their sepsis pathway, and that's all been possible with the optimization work, but that takes a lot of time. So your journey isn't just go live date, whew, we've done it, it's the next 10 years. I've also had the privilege, there's a theme here, first in types. So first in type at Epic. And then the NOVA program recently in Mid and South Essex, which was pulling together the program plan and the structure and governance for the NOVA program, which was 3 acute and a mental health service. One of the things that we didn't focus on was the impact on our GP partners. So that kind of remembering your partners. So we did engage them, or we thought we had engagement, but what you think is engagement is never what is right. So always keep testing. Do they understand? Do you know about it? Because they're like little independent businesses in their own right, but they came together as a group to say, you haven't done this very well. So it was like, okay, lessons learned, let's keep engaging. And that was even before NOVA hasn't even gone live yet. So it's engaging that flow out. And we know now that there has got to be the shift more out to the community. So it's really, really important that acute trusts do that. And then more recently, I'm currently working with Bath, Salisbury and Great Western as their EPR operations director. And we're now looking at organizational readiness now and post-go live sustainability now. What do we have to do? So it's working with operational leads. We do absolutely believe clinically led, operationally delivered, technically enabled, but that operational element, because let's face it, on go live day, it'll be the coups running the show. So we've got to make sure that the organizational readiness right across those 3 groups, again, a first in type for an Oracle implementation, bringing that together. And we're dealing with something new as well, because the group is only forming as a new group. So you're dealing with lots and lots of culture changes there. So lots of conversations going out and remembering the people are in this program. It's more about people than the technology.
Absolutely. Thank you, Kira. Quick question. In the group, is every organisation, every trust, will they be on the same system?
Yeah,
right.
They will be. Yeah, they'll all be on one single integrated module of Oracle. Yeah.
Well, thanks. Mike, did you want to come in?
I just wanted to add a little to what Kira just said. I think MFT did a similar transition, but obviously taking learnings from what went on with Epic. You know, they had a huge problem doing that transition as well. But I think they made a success of it. I came in quite late to work on some ancillary systems. You know, I think they had about 1,000 systems across 10 hospitals. They all still needed access to that clinical history and ongoing operational reporting. Their prep work, from what I understand, was very, very good. Data quality validations, patient index transfers, all those kind of bits, open registrations, pathway migrations. You know, there's just a huge amount that needs to go in, and that needs to be planned. And I think practically with the learning from there, we can take us. You should sort of split that work into 3 kind of lenses. That clinical history access is one part of it. Your operational reporting is another part. You got to make sure you've got continuity of that operational reporting. You can't just leave that off to the side. And then finally, you've just got all this data quality reconciliation. You can't be seeing a drop in your quality through this transition. If any one of those areas is weak, then your clinicians and anybody using the system is just going to conclude that the whole EPR is unsafe or otherwise useless. And once you've broken that, it's very hard to rebuild that trust. It's, you know, I think someone in one of the other webinars said that you know, trust arrives on foot and leaves on horseback. You know, you've got to be very careful about how you maintain your trust. And equally, I think the other learning around that was that paper doesn't disappear on go live day. Pretty much all these transitions have a messy hybrid phase where there's still some paper going on. I think one of the other things that MFT did around that was they spent a lot of time identifying those remaining physical notes and making strong decisions on how long those pieces are actually going to live for, rather than just sort of saying we'll scan it later and building up this huge hidden backlog, which I've seen other trusts do. I'm sure there were still elements of that. I didn't see their entire operation, but I think they took some strong learnings from other people who did the difficult part of going at it first, right? But I think that's sort of a bit of a success story about how you can learn from some of these difficulties and why it's valuable to do it, right? And tell everybody about your struggles rather than try and hide them, because other trusts can take from that and hopefully make more of a success of their transition.
Absolutely. Thank you, Mike. Kelsey, did you want to come in?
2 points. I want to echo the importance of including the community in your planning. And one of the things I think that often gets overlooked is, what do they actually want to see from your EPR? We have the assumption that the more information we give them, the better. And that is completely untrue. They would like succinct information that helps them carry on the journey or the continuity of the patient care. They don't need to see the ECG that you do in the ICU every day. And so the assumption that more is better is completely incorrect. So you do need to engage them to ask them what kind of information do they want to get. And then after Michael spoke, it reminded me of one of the provinces in Canada when they went live with their EPR. It hit the media because they felt like it was unsafe, that the system was changing their orders. And what they didn't realize is they had been ordering things on paper and the pharmacists had been changing them for 10 years. They weren't even drugs on the formulary. And so when they saw them finally come back, because on a paper, you see what you wrote and you assume that's what the patient is getting. You don't see the response back when the order changes. They went to the media. It became a big deal that they thought the system was changing their orders. And so understanding that current state workflow in those situations where things like that are happening before you go live is paramount.
Fantastic. Thank you, Kelsey. Ian, would you like to come in?
Yeah, just to pick up again on something that Michael said around lessons learned. Again, we'll probably talk about it later, but it's so important, in my view, to understand what went badly as well as what went well in trusts, because I don't think the NHS is very good at sharing information at all, and it certainly, in my view, is not very good at sharing honestly about what went badly, and there are lots of reasons for that, and that's how it is, I guess. But there are lots. I'm sure all of us, I know I have been involved in things which didn't go well, and that teaches you so much, and that you can learn from it, and want to share it with others, because some of it, when you've done it, got it wrong, is so obvious, but not necessarily something you would have immediately thought of. So let's be more open with each other and share some of the bad stuff as well.
Absolutely. Great point. Thank you, Ian. Kelsey, could I come to you? So Kira's spoken about momentum after go live. In Bermuda, you're 3 years on from go live. How have you worked that phase and that period in terms of keeping momentum and going through improvements, customization? I guess go live is the start. What have you done after then?
Go live is the easy part, quite honestly, I think. We all think it's the big event, but it's trying to keep everyone settled as you optimize going forward. So we've essentially had an optimization program since we went live. We try to work through the highest priority items. Certainly there's things that we needed to change that at the time of design, I don't think we understood some of the implications of them. And so trying to make everyone understand that we are a very small team. We're probably the smallest team I've ever had working on the biggest solution I've ever implemented, quite honestly, from a scope of module perspective. And that, we tried to do our best and engage people, but it's tricky. End users start to become a bit disenfranchised if they don't see changes happening. So it's also trying to communicate the work that is being done, because a lot of it is behind the scenes. One area might see it, but the other areas don't. So I think the communications that you have going into go live are equally as important as the communications you have post go live, so that they do see that there is progress being made, even if it's not necessarily in their specific area.
Fantastic. Thank you, Kelsey. Mike, did you want to come in?
Just to echo and expand a little on what Kelsey just said, really, there, which I think that go live is obviously a really important point, and if you've done your planning right, the go live should be easy, but also that you know, the benefits of doing one of these transitions are real and measurable, but they often arrive later than a board would hope. So NHSE cites, you know, better outcomes and productivity from the more digitally mature trusts, but our experience shows that significant progress and reporting changes will continue well after go live. Right, there's like a 12 to 24 month realization for actual benefits. You know, the first big thing about safety and continuity is really important in and of it all, but really to start realizing those gains, you really the organization has to settle into using that. You know, boards tend to expect, you know, immediate productivity gains, and that often creates the wrong pressure at exactly the wrong time, and that's an important thing to try and manage from my experience.
Thanks, Mike. Kelsey, would you like to come in?
So I think the immediate productivity gain phenomenon is really it's a fallacy. And I mean, I tell people it goes in 3 days, 3 weeks, 3 months, 3 years, is how you have to measure that productivity sort of gain. And in those first few months, you will see a detriment to your productivity. There is no question. And it's really hard for end users to go from being super users essentially of their current system, whether that's paper or a different system, to being technology challenged. And the cognitive load of having to think about every step that you take is really trying on end users. And I don't think we speak about it enough, so that they, at the end of the day, they are going to be exhausted after a shift. And that's going to happen for at least 3 months. And I think one of the things we did well was actually telling people that. I don't know that everyone goes into that. They want it to all be rah, rah, it's going to be great. And that's not setting them up for success. No one moves to a new system. I got Windows 11 the other day, and I'm still challenged with trying to figure out how to use some of the functionality of it. You know, Apple pushes out a new update, and it takes me 2 weeks to figure it out. And these are small incremental changes, and we're talking about monumental changes to their workflow.
Thanks, Kelsey. Ian, would you like to come in?
Yeah. I think that there's sort of what happens after go live is the thing that most people who've not done it don't understand. And that is all the things that people have already said. But, you know, you need to have a plan for after go live as robust, if not more so, than what you had to get to go live. And I was talking to somebody the other day who was in an EPR program, and they were close to going live, and he was telling me, I don't know, working 12-hour days and how it's great it's going to stop because we're going live soon. And I was thinking, maybe not the 12-hour days, but trust me, if you think that somehow, you know, it's all sweetness and light, forget it, because that is all the things that Michael and Kelsey have been talking about, and it's the perfect place to lose everything you've done. And there's no escape. There's nowhere to go. There's nowhere to hide. So you've got to be absolutely relentless. One of my favorite words. You've got to be absolutely relentless after go live on sorting out issues and managing it. And one thing that I just picking up something you said earlier, and you know, and this is going to sound a bit detrimental to somebody. It's not meant to. It's just the reality that I've seen. The people that are most affected on go live by what happens on go live is the chief operating officer and his or her team, and because they're dealing with the problems, or they're seeing them manifest in front of them with what longer waiting times in A&E or whatever it is. But usually, not always, often perhaps.
Thanks, Ian. I think you might have frozen there. Kira, could I come to you, please, in terms of the chief operating officer role?
Yeah. So I just staying on the post go live theme. Yes, go live on the day. I was the director on call for that epic overnight, and then it was just the pressure on operational teams and clinical teams, and the pressure we were under for them to go, this isn't safe, we're going back to paper. We want to go back to paper. It's about holding that line, keeping that vision in front of you, and riding that very difficult wave of change. This is, you know, thankfully, the NHS has got better at implementations. We've learned lots of lessons, but post go live, once you calm down after those first few weeks, you've got to put relentless focus, and I'll go back to Ian talking about a plan and Michael talking about your post go live plan. You've got to put that focus on that clinical time, because clinical time is the prize. 63% of benefits is around clinical productivity, and that came out in a recent Future Health Intelligence report. So work with your clinicians that your whole post go live plan has got to be around that optimization. So your reporting, etc., will come along, but focus on that clinical productivity and time, helping them get used to the system, optimizing the system the best way that works for them. And you will have rebuilds to do. You can't get away from it. There will be one area that has not been built properly. So you've got to laser focus on that to get them back up and running as best they can. So your go live date is great, celebrate, etc. But the prize is in that clinical productivity time and driving that post go live.
Fantastic. Thank you, Kira. Ian, can I just check, are you with us or is technology
I
one?
think so.
Yeah, I can hear you okay.
Yeah, I was just putting in the chat, as I said at the start, I had BT came out and mended my Wi-Fi yesterday, and of course it just failed. But I'm now logged in back via my phone, so hopefully you can hear me.
Yes, can hear you okay. Thank you.
I can't see any of you for some reason, but we'll work on that.
Thanks, Ian. Right, Mike, did you want to come in? Sorry.
Yeah, I just wanted to highlight that, just to further everybody's comments, really, that you know, the handover from program to BAU is a genuine risk that must be recognised. It's not just an administrative step that is often considered. Like one of the very practical issues that have been reported and I've run into is confusion over like who owns an incident with the system. You know, is it the supplier? Is it local digital ops? Is it service teams? Like who is actually do we need to reach out to when we run into a problem, and how do we define that problem and who owns it to actually get a fix? Designing that operating model before go live can save a lot of headaches. You know, service desk triage, optimization, because they're not very pretty or glamorous things that you need to do, but they're really important aspects that can massively impact that trust and that confidence in the system over time, because problems are going to happen, and assuming that they're not is a surefire way to fail, right? Like we have to assume that problems are going to happen and that we have a sensible way of handling them rather than just assuming that everything's going to go well. And I think that's something that as humans we don't like to do. We don't like to think about the worst case scenarios too much, and people that do are seen as negative when in fact what they're really doing is setting up the program for better success when we try and, you know, put mitigations in for those worst case scenarios.
Thanks, Mike. Kelsey, we've had a question in the chat around cognitive load for 3 months, and the question is, would follow-up training at the 3-month stage be too much or would it be useful?
So I actually think that classroom training has limitations. It's not really giving the real world situation. I would be more likely to have better rounding and at the elbow support for a longer period of time, so that you're actually meeting the clinicians where they are. Taking them back into training is too generic, and probably not answering their questions that they're really having. And you need to see them navigate the chart to understand where they're maybe not optimizing their workflows. So I would be a much bigger proponent of having an at the elbow support team. It doesn't have to be your vendor team. It could be your informatics team and things like that, but having them be really on the floor and seen and being a trusted partner.
Thank you, Kelsey. Kira, would you like to add to that in terms of 3 months on and the training piece?
Yeah, ongoing training completely. You've got to keep doing the system changes all the time. So you'll be getting upgrades each year. So it's got to be part of almost mandatory training, or if there's not much changing, at least clinicians and operational people are aware of what changes. I think a good learning management system is really important for your pre-go live and organizing your training, but also your post-go live. And remember that people learn in different ways. Some will like video, some will like at the elbow, but I'm a great advocate for at the elbow, because then you can, as you say, Kelty, you can see people navigating through the system. And in your pre-go live planning, having your super users within the areas trained in their areas and maintain that training for them. Post-go live, they still have a really crucial role to support their wards, their clinics, and their areas. So yeah, you've got to invest in a lot of training and ongoing for the remainder of the time of your contract, really.
Fantastic, thank you. Could I ask a quick question? So if there's one thing that you could change from your EPR journey, go live, post go live, just what, or anything you change it with the systems or interoperability, anything actually. If there's one thing that you'd change in the EPR landscape market, what would that be from your experience? If you could change one thing, anything. Mike, could I come to you for that one first, please?
Yeah, I'd obviously quite selfishly, I would want trusts to spend a bit more time planning for their resilience, downtime, and recovery. You know, that back to that point about failures are going to happen. And I think we sometimes have blinkers on about like the new system's just not going to have any troubles for the first N number of months, but that's actually when the systems are most likely to struggle and collapse. I think there was a bit of a horror story about a certain trust that I won't name, but they had too many numerous complex interlinked legacy systems involved, and their recovery that they thought was going to take days took weeks, you know, before they were back operational again. And had they done some more operational planning about their true recovery and actually done some rehearsals of that and tested their downtime and their SOPs around that and verified their alternate communication channels, they could have limited the damage in that space, and also hopefully understood that recovery time. And I think that, you know, that's something that is often overlooked during the somewhat frantic desire to get rolled out.
Great point. Thanks, Mike. And Kira, same to you. One thing that you would change.
Change. I would make sure there was investment in change post go live. If we think about a business case, we have, you know, most people are saying they're going to have X millions in cash releasing, X millions in non-cash releasing benefits, and the X million in societal benefits. You cannot deliver that if you just give people the computer and the tool. That just won't happen. So in full business cases, I'd like to see that people are putting in investment for change. Often with costs, it can be taken out because you're trying to make your case work, but it's crucial that before you go live, you are already building in that case for change, for delivering those millions of benefits. And if we go back, and I think the evidence on most people say, well, do IT programs really deliver? They can if you invest in the change and deliver those benefits. If we were Google and we had a £100 million project, we would make sure we're putting in the right people and the right change tools to drive that delivery of that 100 million business case. So we've got to think like that. It's not just for go live, as we've said earlier, it's that next 10 years and optimizing for the benefit of our staff and our patients.
Great point. Thank you, Kira. And Kelty, same question to you, please.
So HIMSS says many years ago, and I think they're right, that 70% of the return on investment in one of these systems is in care transformation. And so if you're not actually looking at transforming care, you're probably just putting in an electronic version of a paper process. And I would say that's very common, and it comes to do with that pre-planning. The vendor is not engaged to do care transformation. They're there to implement a technology product. And it's up to the organization to be thinking about what do they want to do to deliver care? What does care look like? How do we standardize? How do we reduce duplication and nuances in care? And I think if there's anything I could change, it would be that upfront planning had occurred.
Thank you, Kelty. We've got a question in the chat. Kira, could I come to you for this one? It's before an EPR journey starts, what's the readiness assessment that needs to be done, and what are the dimensions of the readiness assessment?
So there are many dimensions, but I think if we take it from a triangulation point of view, your people, your process, your technology, and then as you move, you can have organizational readiness checklists, which will have how's your leadership engagement, how is that right up, not just across your executive, because we all know executive buy-in is really important. But executive teams change and move in. So where's the leadership engagement right through all those levels? How is your clinical readiness? Do your clinicians understand that end-to-end flow? Have they been involved in those workflows? Have they been involved in signing off their workflows? And then the medical staff readiness around training. Then you've got digital environment and downtime planning. Which is we've already talked about. You've got all the work stream sign-offs to do. Are you ready? And then the training, and then that transformation and change readiness for the future. There are a few more, but that's just off the top of my head.
That's fantastic. Thank you. Mike, could I come to you next in terms of the period after go live, and for those organizations on the call that might be in the stage of trying to add more value, customize the system? What's the best approach from your experience, and what's key to making a continuous impact with an EPR?
Well, we've kind of touched on everything that I'd want to say in here already in terms of the prep. It's the same thing carrying on. I've spoken previously and as an organization on what we would call like an evergreen approach to EPRs, and that's trying to remove the notion of this one big bang go live and turn it into a continual improvement journey. So it's not just about us hitting a date and carrying on from there and all the benefits are realized. You know, clinical practice changes, staff change, organizations change and grow, and new services come on board, and all of those things need to cause the system to need to adapt. And if we aren't assuming that this system is going to change over time because we've front loaded all this work onto this go live date, then we're setting up the system to fail. We're setting up what people needing to create workarounds for this system because it can't handle this new workflow that we've put in. So treating them as evergreen and as ongoing projects for me is one of the most fundamental ways that we can improve that situation. You know, it's done in the way that the grass is mown. It's going to need mowing again in a couple of weeks, right? That's just the reality of the world that we live in. We are not in a fixed static environment, and healthcare in and of itself is actually extremely rapidly moving in so many ways. You know, patients change, the demographics change, as well as our practice needs to grow and develop, and our systems need to adapt to that as well.
Great, thanks, Mike. Kelsey, would you like to come in?
I think one of the things that's really important is to understand that end users often speak in solutions, and you need to take them back to what is the problem they're trying to solve. Because they don't understand some of the intricacies of the system to actually define the best way to solve it. And if you were to answer the question in the solution that they're asking for, you're probably not implementing the most elegant way to do it. There could be many other ways. So that would be one of my pieces of advice, is always go back to what is the problem you're trying to solve.
Fantastic, thank you. Ian, I'm keen to hear from your organization, and are you in a phase now of customization and trying to get more value out of the system, and how are you doing that? Is there anything that's worked particularly well?
Yeah, so I mean, it just a lot of it is echoing what we've already said. So as I said, we went live in 2015 originally, but we did a sort of major kind of relaunch, if you like, reset, which finished in October last year. So that built the platform that in some ways was a bit like going live, but it wasn't, because we'd had it for 10 years. But what we followed it up with was a second program, which is already underway for the next 15 months when we started, where we're basically building on what we've done. So it's delivering more functionality, it's solving more problems. And I would 100% echo what Kelty said there about problems. Bring us your problems, don't bring us the solutions, because you know, one of the things that we need to do is work out the best way to manage those problems, and also recognize that the problem that you're bringing to us may not be the right problem in itself, because it might be based on the fact of how you did it in the past in the old world and the old paper systems and so on. So there are now, that's why, what is it you're trying to achieve? And then we'll look at what we've got to help you do it. So we've got a program with probably 7 or 8 different elements to it, which we badge and brand as one thing. We give it a very specific programmatical approach so that people can see it and touch it and feel it and know what it's and that will be running through, as I say, till March 27 now. And I'm 100% sure that we'll have another one after and another one after, because it's never ending. There's always going to be something to do. And I think sometimes people think, oh, when are we going to finish this? Well, the answer is never, because as people have said earlier, patient need is changing, the way we deliver service is changing, technology is changing. I think we'll talk about that a bit later, and I think that's going to have a huge impact. So it's a constant moving feast, and you've got to, one of my other things, deliver. Tell people what you're going to do and do it. Keep your promises. And that keeps the confidence high. Sometimes you can't do something, you've got to tell people that as well. But if people see you delivering, they will have confidence in what you're doing. But you've got to, it's constant. It's never going to be something that you go, oh, we've done it now. It's never going to happen.
Great points. Thanks, Ian. And picking up on that, how do you manage speed and people's appetite for, say, technologies like AI, but doing so properly with governance and taking time to do it safely? How do you balance those two? Mike, can I come to you for that question first? What's your view on that?
It's one of the big problems that we run into nationally. We would like people to realize the kind of gains of things like AI, but ensuring that we do them in a clinically safe way is a standing problem, right? Observability and explainability of these processes remains paramount and is somewhat lacking in a lot of these scenarios. How did a model come up with a particular answer is a problem that has occurred since before the moniker of AI was put onto these models. Like we just do this predictive analysis and how do we explain the results? Sometimes we can't, and that doesn't usually end up with something that we can clinically sign off on. We go through some extraordinary onerous processes to qualify a model as a medical device, and that is an area that we will continue to struggle with as we as a landscape attempt to sort of adapt and align with these new technologies. It's the same story with any new big technology, though. It's just that historically you could poke around inside of a piece of technology and understand what it does and prove the safety of them, whereas we haven't yet as a discipline figured out how to explain these things internally. And I'm sure we will in some way, shape or form, we will build some clinically safe models that have passed whatever validations we have, but currently I don't think we're in a point where we can safely utilize them. And despite the need or the want for that, that's not to say that we're not working overboard to try and make these models more explainable. That is an understood area of concern. I just don't think there is one yet that ticks all the boxes.
Thanks, Mike. And Kelsey, could I come to you? Keen to hear about, is this the same challenge in Bermuda in terms of new technologies and keeping up with those?
Oh, yes, absolutely. And trying to keep people from using the technology that hasn't been assessed. How many people are using some version of an LLM in their day-to-day? I know my clinicians are. And, it's almost impossible to stop. We can put all the policies in place that we want. It doesn't mean that they're necessarily always followed. And, it's really hard when someone's found something that really helps their clinical program. And, IT is always seen as saying no. And the challenge of being the no people. How do we assess them in a reasonably fast way? What do we assess them as? How do we roll them out? How do we put the right guardrails around it? Is a massive challenge, because as fast as we hear about a tool, someone's already using it. The tools that we control the most are the ones that are in the EPR, because we can turn them on and off. But that doesn't mean, that the other tools that are out there on the web aren't being used. And I think we're kidding ourselves if we think that they aren't.
Great points. Thanks, Kelsey. Ian, we've had a question come in the chat. I wonder if I could come to you first on this one. It's around what are the key important areas or workflows that sit outside of the EPR? One example being one challenge, perhaps being ERS and inbound acute referrals will be a big one. Have you any recommendations on those technologies working outside of the EPR, and how are you managing that in Surrey?
Yeah, thank you. So we've kind of described our EHR and our EPR in slightly different ways. So EPR we kind of think of as our system one, that's our, simplistically put, our out of the box EPR solution, but our electronic health record includes those other things. So when I said earlier that we've got a follow-on program of activity, probably 75% of that is other stuff. So for example, a referral portal, linking our EPR into the NHS app, that kind of stuff. So, you know, this, we all live in different degrees of complexity of the number of systems that we're managing with. Probably mental health has fewer than acutes, for example, but it's there. So interoperability is really important. And one of the things that I would have said earlier about, except I fell off, I think, at that point, about what I would want from an EPR suppliers is, or what I would change is they've got to work together more. Not just EPR, all suppliers have got to work together more. They exist in an ecosystem. None of them are standalone systems. So that's really important. But I think also you need to think about how you sit in your whole system. So, you know, how do you sit alongside your ICB, your community trust, your acute trust in our case, or mental health trust if you're acute? How are you all working together? You've got to be working and talking together about how you're going to do this stuff collaboratively, because I think sometimes these things are not well done because we always think of ourselves as an island, but we're not. And I think the other thing, particularly on the PEP front, I think the national move now is more toward direct integration between NHS app and EPRs. And as a patient, and I've had the joy of being a patient quite a lot recently, unfortunately, I think that's a real crucial thing, because I don't want a multiplicity of PEPs. I want one place that I go to get all my health information. I don't care whether it's mental health, acute, or even private. I want it in one place. Yeah, so I think we should be working much more collaboratively on a lot of these things.
Great points. Thanks, Ian. Mike, would you like to come in?
Again, just want to further expand on the great points made there. You know, patient journeys, you know, cross trust, cross organizations, that interoperability is much more important. You know, convergence and interop is much more important than just EPR coverage in a single space. These things aren't islands, right? They are literally interconnected webs. I want to go between my primary, secondary care and aftercare and ensure my records flow. And I think most patients assume that when they go to their GP and then follow up and go to the hospital, that they know what's happened in either building, and more often than not, they don't. You know, I think when we start to treat these solutions not just as an EPR but as an end-to-end pathway, that's when you start to see real gains occur. You know, don't just look at the one little piece. Really start looking at that whole journey, not just for the patient. So you've got to look at it for the clinicians and the support staff. How does it sit in the broader ecosystem rather than it just being a singular piece, a single technology piece? And yeah, as rightly pointed out in the chat, shared care records are one piece of that broader puzzle, right? How do we ensure APRs and EHRs talk as part of that landscape of shared care records, which again are now becoming more regional items. We've not quite understood how we're going to do this nationally yet, but it is an ongoing piece that we are trying to achieve, and that will allow and enable those kind of journeys that people expect, where they get to go to their GP and then also end up in the ER later that night, and they know full well what has been prescribed to them, which, you know, is obviously a huge risk right now. And same thing in mental health. You know, you can go to your GP and you can go to see a mental health practitioner, and neither side knows what's been prescribed to each other. That's an awful risk from my perspective, and really does deserve to be more joined up.
Great. Thanks, Mike. Right, we've had Oh, Ian, would you like to come in?
Can I just make a slightly political point on that last thing, which everything I agree with, which is that one of my concerns about the changes that are happening at the moment is that we're losing potentially losing that joined up system-wide approach. Now, I'm not saying it was as strong as it could be or should be in places, but there's a real risk in my view that we're going to lose it. I think the changes that are happening with NHS England and so forth with ICBs are going to reduce the amount of time we work together, not increase it. And that seems completely contrary to the 10-year plan and what every patient and clinician needs.
Great points. Thanks, Ian. I think you've frozen us slightly. So we've had a question come into the chat. Kelsey, could I come to you for this one? How do you measure EPR ROI in terms of patient-centered care outcomes?
A great question, and something we certainly struggle with here. We are a very, very small country. We're only 65,000 people, and we have to have a system that would typically support a catchment area of a few million. So the ROI is tricky in that sense. But I think when you look at continuity of care records, medication safety alerts and management, discharge planning, things like that, that's where you're going to really find those patient-centered care outcomes. There's definitely the safety aspect is definitely the place that I would be looking for most of the ROI. But there's also some administrative ROI like that people forget. You can access the chart from anywhere. You can look at the chart from home. You don't have to come in if you're on call. Those types of lifestyle ROIs that I think we often overlook the value of. You don't need a call room where everyone sleeps overnight because the paper chart is there. People can have the chart open in multiple places at once. Those would be the types of things I'd be looking for.
Great, thank you. And I've got one more question, and then we'll cover any audience questions. We've got 8 minutes, so we've not got long. My question is, what should the ambition be for EPRs by, say, 2030? So in the next 3, 4, 5 years, maybe, what should the ambition be? Kira, could I come to you for that one first, please?
Yeah. So I think so the ambition for EPRs deployment, we'll take it as John. Shall I take it as that?
Sure. Yeah.
So I think it's developing that digital maturity within organizations, because we know many of our organizations are not digitally mature, so we'll leverage us up to compete with Europe and the rest of the world. I think it's building on that clinical productivity. They've got to support and deliver on that clinical productivity. Now, we have talked about people process change, helping that, but your EPR suppliers should absolutely be relentlessly helping you drive that as well, so you can drive your benefits for your change. I think integration, which Ian mentioned earlier, around integration with your partners and out to your patients as well. We know with the return on investment element, societal benefits is a huge piece of EPRs, so we need to focus on that. So I think integration between suppliers is probably, if I was looking from a supplier point of view, definitely they would need to be focusing on that and how we integrate with the GPs and our patients more. At the minute, EPRs are still very acute focused. So that's what I think the ambition should be going forward.
Great, thanks, Kira. And Ian, the same question to you. The future of EPRs, perhaps in Surrey, what does that look like? How does that align with the 10-year plan? What's your ambition?
So I'm going to slightly answer a different question, if I may, because the future of EPR in Surrey, I think, is probably, I mean, just to talk about Surrey specifically for a moment, I think the 3 acutes all have Oracle. I imagine that they'll come together more. I think the shared care record or Surrey care record will help us to bring the data together more in the way we talked about earlier. But I think the future of EPRs is interesting, because I think the future of EPRs is going to reduce significantly, right? Because I think, do I have a lot of evidence for this? Not yet. I think AI is going to change the way that clinicians and patients interact with technology and data, such that EPRs will probably end up being more a repository of data rather than the tool that you use as a clinician to access that data. Now, that's a big generalization, and I'm just being deliberately slightly provocative in saying it, but I do think in 10 years, 5 years, the way that most clinicians interact with EPRs will hopefully be very different. And I say hopefully because we all know, don't we, that one of the problems with EPRs is that we've shifted an awful lot of work onto clinicians that used to be done by people like medical record clerks and so on. And, you know, the way that people interact with technology needs to change dramatically to make it really add value. And I think AI, AVT is an example of that, perhaps, will really help do it. How it's going to do it, when it's going to do it, I don't know. If I knew that, I'd be investing in it if I had any money. But, you know, I do think it's going to change dramatically. Yeah.
Thanks, Ian. Mike, what's your view on that?
So I did a thought piece around almost exactly this this question that I called the Everywhere Hospital, which talks more about, and I'll try and summarize this as quickly as I can into a few points. EPRs should be like longitudinal, not organizational. So a hospital EPR on its own is no longer really an adequate end state from my perspective. You know, connecting care records work is about giving, you know, authorized professionals that kind of person level information. By 2030, I think that ambition should cover like the full journey of health through everyone's complete life. EPRs should be active workflow systems, not just document stores. You know, they should completely and reliably support that sort of closed loop medicine, structured documentation, order comms, all those other bits and pieces, referrals, everything. The patient should be a participant in it and not just an external viewer from my perspective. That's another part of bringing a patient along on the journey. They are an active participant in their own health, and bringing them along on that journey should be an important part of how EPRs work. Final couple of minor points, operational intelligence as a standard rather than an add-on. You know, we want to be learning and doing diagnostics and productivity analysis as part of it. As a core part, as a core piece. With that, and talking about AI and the future, you know, cyber resilience and downtime safety are non-negotiables in this space. You know, that if we're going to make that work, we absolutely have to ensure that it is fully resilient at a national level. And finally, then the most important part of all of this, success is measured in outcomes, not in installation count. You know, I don't care how many people are using it. I want to know that the outcomes have been improved for patient care and for everybody in the whole system. And so those are my kind of headline points about the Everywhere Hospital, really.
Great, excellent. Thank you for that, Mike. And Kelsey, could I come to you in terms of the next 3-5 years? What's your ambition?
I agree with Ian. I think the whole concept of the medical record is going to be shifting. A lot of it has been administratively documented for billing purposes, depending on where you are. You know, the whole system was originally designed around transactions, and that's not necessarily what you need to deliver the best patient care. I think AI is going to shift the lens to make it so that things are summarized. You can find information easier on your patient. It's going to change the whole, and it's going to fundamentally change it from when it was paper, because no one was ever reading all of those records. And we essentially modeled that with the current EPR, is that we have a paper version of an electronic version of that paper process in many ways. And I think AI is going to fundamentally shift that and change how people deliver care.
Fantastic, thank you. It's 10:58, so I don't think I can squeeze in another question. Oh, Ian, would you like to come in? If we have you, Ian.
Well, it was only to say that going back to my point, which Kelsey was kind enough to agree with.
I think it's breaking up too much.
Sorry?
I can't quite hear you.
Can you hear me?
Oh, I can now, yeah.
Can you hear me? Oh.
It's slightly better. Do you want to give it a go?
Can you hear me?
Yeah.
Can you hear me now?
I think technology is being
sorry, I'm really sorry about my. As I say, VT came out and fixed it, and they didn't. But
Don't
I was just
worry.
going to say, I agree. That my point about AI absolutely is whether. Sure. Oh, well, okay.
I think
Sorry.
technology has beat us there, Ian, and it's 10:59, so I think I'll have to close the session here. But we can catch up outside the call. It's been a fantastic panel today. I've really enjoyed it. Kelsey and Kira, Mike, thank you for taking the time out to join us. It's been a fantastic hour. Lots of learnings. It has been recorded. There will be a write-up done by the HTN team, so you can digest that after the session. But it's been a super hour, lots of learnings, very practical. So really appreciate you taking the time to join us. And thanks to everyone in the audience as well. It's turned 11. I'll close the session here. Thanks, everybody. Have a nice day, and we'll see you on the next webinar. So cheers all.
Thank you so much.
Thank
Thanks.
you.
Bye.
Thanks, everyone. Cheers. Bye.
Thank you. Thank you.